Hi, and good afternoon. So I'm Lauren Guy. I'm from the London School of Hygiene and Tropical Medicine, and I'll be presenting a study on the association of water, sanitation and hygiene and animal ownership with relapse to acute malnutrition following recovery among children 6 to 59 months in Mali, Somalia and South Sudan. This was a prospective cohort study, and I'm presenting on behalf of all of my multiple co-authors from the 3 countries and different organisations. So studies have confirmed severe enteric infections in severely malnourished children. There's particularly symptoms of illness include diarrhoea following anthropometric recovery from SAM. Now, when you see this causal framework, inadequate access to WaSH exposes children over and over again to enteric pathogens, threatening their nutritional recovery and other related health outcomes. But to date, there's been only 5 studies really looking at this post-recovery period and looking at the association of WaSH to relapse to acute malnutrition. So we conducted a prospective cohort study in 3 countries, enrolling a cohort of children who were 6 to 47 months, because we allowed them to age up, who had been enrolled in SAM treatment in the 3 different countries, so that's treatment for severe acute malnutrition. We enrolled them at the point of discharge, so they were recovered, and followed them for 6 months. We took a series of multiple different data collection methods, from household surveys to household drinking water, child food samples, observation of child food preparation and feeding practices, and rectal swabs, where we tested a suite of enteric pathogens, antimicrobial resistance and microbiome analysis. But for the benefit of today, and because it's the first study that's coming out, is just looking at household surveys, so thinking about the WaSH conditions, and then looking at household water. And all of the other studies are coming, but it's taking us some time to analyse all of that data. And so just for reference, our 3 study sites were Mali, South Sudan and Somalia, all countries that experience repeated and protracted humanitarian crises, all have a high burden of acute malnutrition, and all have community management of acute malnutrition programs in each of the settings. You can see the stars or yellow dots in this instance, which is where the nutrition sites are. So we have a mixture of rural areas in South Sudan, near the Sudanese border. Mali was a peri-urban and rural setting, and then we have an urban IDP camp in Mogadishu, Somalia. Our primary outcome for the study was the cumulative incidence of acute malnutrition measured through MUAC and weight per height Z-score, and the presence of nutritional edema over a 6-month observational period. We have results disaggregated as well for moderate acute malnutrition and severe acute malnutrition. So, our first results. In Mali, we enrolled 247 children. 242 of our children completed the 6-month follow-up period, and 32% of our children relapsed to acute malnutrition in that 6-month period. In South Sudan, we enrolled 515 children, 488 completed that 6-month follow-up period, and 63% of our children relapsed to acute malnutrition in that 6-month period. And finally, in Somalia, 238 children were enrolled, 234 completed the follow-up period, and 21% of children relapsed to acute malnutrition. Now I'll take a pause for a second, just to reflect on the relapse rates in these conditions and what we're seeing here. And these are children who've been through a treatment program and are relapsing at rates that we shouldn't be seeing in this setting, or at all, and they're going to have to re-enter treatment. And this is a recurrent cycle of coming back into treatment, and these children are coming back over and over again. What we will also look at, not today, is the cost of that recurrent treatment for children entering back into CMAN programs. So let's look at the WaSH risk factors. I'm going to jump to what they are, just because it's interesting and that's what we're here to think about. So in Mali, use of multiple drinking water sources was associated with a greater risk of relapse. So the diversification of water sources, a mixture between both improved sources and unimproved sources or surface water. Thinking about hygiene, a lack of soap in the household was observed to be associated with a greater risk of relapse. Everything okay?
Everything's okay.
Okay. Yeah. And then lastly, in terms of animal ownership, we actually found that households who owned sheep were associated with a lower risk of relapse. So a protective effect for these households. All models were run with adjusted for age and gender, wealth, weight per height Z-score at discharge, which could be an indicator of that risk of relapse further on down the line. And in Mali, we adjusted for water source and sanitation facility. Now in South Sudan, it was a slightly different picture. The use of unimproved or surface water sources was associated with a greater risk of relapse. In terms of sanitation, just for reference, 77% of the population in South Sudan practiced open defecation. So open defecation here was, again, associated with that greater risk of relapse. And lastly, when it came to animals, if there was observable animal feces in the compound, an area in which the children were having contact with, there was a greater risk of relapse. Now in South Sudan, slightly different context to our Malian context, ownership of cattle is a more common kind of ownership of animals within the setting. So household ownership of cattle was associated with a lower risk of relapse. Again, thinking along those kind of wealth characteristics and where potentially the money is stored, but also thinking about access to animal fats, to meat, and different dietary diversity. You'll see from the earlier slides in our methods, we are going to be looking at some of the food kind of preferences, the diets, and kind of aspects of child feeding practices, but that's for another study that hopefully I'll present next year. Anyway, so again, the model is adjusted for age, weight, wealth, gender, and weight for height at discharge. Now in Somalia, you can't see the results here, we didn't find any risk factors for relapse. We're still trying to really understand this and kind of pull it apart from our research team. But in Somalia, we had a kind of an IDP context, it was an urban environment. The coverage of WaSH and the WaSH conditions were much higher for this population. We didn't see surface water use, we didn't see multiple uses of drinking water. The WaSH conditions were a lot higher. There was also receipt of cash and intervention kind of programs and voucher-based assistance. So we're really trying to unpick that to really understand, but we didn't see anything in Somalia. But actually, I think this is quite interesting because across all settings, and I haven't presented it here for time, all of the children were living in areas of poor WaSH conditions, in levels that we don't want to be seeing. Poor WaSH was associated, as I've shown, with a greater risk of relapse. The risk factors, though, as I've presented, are very heterogeneous. There's lack of kind of evidence for one single factor, or any kind of group of factors, really, across the study sites, suggesting that there's a really, really mixed and nuanced interplay of factors that are kind of overlaying each other to really predispose these children to relapse to acute malnutrition. But what I want to focus, and I think what we're really centering on the study, is that this period of initial recovery of the child is a really risky period. Okay? These children may be anthropometrically recovered, yeah? They meet the criteria of MUAC, MUAC being middle upper arm circumference, or they reach their weight per height Z-score, they're reaching these things that we think are the attainable thresholds for recovery, yet they are remaining incredibly vulnerable. Perhaps biologically, and we might be able to do this in our study, see that they're still at risk. So what I'm really focusing, and I think with this is a collaboration with Action Against Hunger and many other partners, is that interventional efforts here, we need to think about that post-recovery period. You know, the children, once they've finished the CMAN program, they've finished their treatment, that's kind of the end of story. And so we need to think about that post-intervention period, that post-recovery support, and really needed to sustain that recovery further and kind of think about that exposure pathways beyond that initial period. And so just a massive thank you to kind of study participants, their caregivers, the amount of time. The study took us about 3 years to kind of back and forth and coming back to the facilities over and over again. But our nurses and data collection team are kind of partners across South Sudan, Mali, Somalia at the Ministries of Health, Action Against Hunger in all 3 countries and the US, and then collaborators both at LSHDM, but Tufts University and University of Washington. And so just to kind of, everyone's got a QR code these days, so it's kind of fun to add. We do have a protocol which kind of states our analysis plans and all of the kind of variety of data that we collected across the study. We've just about published, or just about to, and coming out in December 2024, in Lancet Global Health will be the rates and risk factors of relapse, which really centres on the individual and clinical characteristics. My preprint wasn't quite approved just in time for UNC, but we have a preprint for the WaSH factors that are associated with relapse, and we're going to have a series of other things that we're looking at. But really, I think we've got to redefine some of the things that we think about in relapse. We're leaving children in this very vulnerable state, we're kind of not knowing what to do next, but how do we define this relapse to acute malnutrition and this vulnerability that we're continuing to see in this population? Anyway, thank you very much for your time.
Thank you very much, Lauren. Any question in the room for Lauren? We have about over 10. Can I just see in the room, if you've got any question, can I see your hand? Okay, 2. Right, I'll start from the back.
How long is it between the recovery and relapse?
Yeah, so the primary outcome for this part of the study is kind of entire observational period. So it's a cumulative instance of relapse within that time. So any child that relapsed between the 1 to 6 month period counts as a relapse episode. We also have data on the time to relapse, so if it was within 0 to 1 month of follow-up or 0 to 2, so on and so forth. We also have the number of relapse episodes because some children in our study relapsed multiple times, and also to what degree. There's kind of a few different outcomes, but for this part of the study, it's just the cumulative instance overall.
My question is really, you've worked in some very challenging contexts. You've done research at, we've seen quite a lot of this research in places like Kenya and Bangladesh, but these are really challenging contexts. And what are your top tips for people trying to work in contexts like that, or what challenges did you face? Give us some reflections.
Yeah, so one of our biggest challenges was COVID-19 actually. So we started the study in 2019. This is BHA funded, thanks to the funder, and the study had to stop because the contact that we were having with the children to do anthropometric measurements was deemed not possible. So that was already our first challenge. Our second challenge is the supply of any of our materials took months to get into these settings, right? We're relying on UN systems and UN planes to get our teams in, to get all of our materials in which to do this. We're also relying on teams that are incredibly stretched, right? We're working with Action Against Hunger, who are an incredible organisation, but we're borrowing lots of capacity from their team when they're kind of doing humanitarian and crisis emergency operations. So just balancing all of those things. There's also aspects of the study I haven't talked about today is the stockouts that we were seeing for nutritional programming and everything else that comes with this. So wondering what kind of influence that might have on some of the results too. Otherwise, it was great. Like, the teams are amazing and are like really hardworking, and I think that's the same across all contexts. But I think there's some nuance in the challenges of getting research accepted by some of the ministries of health, perhaps in some instances as well. Just the approval systems were slightly not really there, like ethics boards not existing, and who do we go to for kind of reference groups and things like this. So some of those challenges I think were experienced as well.
Additional questions? No? All right, thank you, Laura.
Thank you very much.
So next we have Joshua Miller from UNC. All right.
I would be that one, yes. Okay, I'm setting a timer. I tend to put way too much information in slides and then miss all the good stuff, so I'm going to try to be better about that today. Hi everyone, thanks. Thank you. Yeah, as mentioned, a doctoral student here in the Department of Nutrition, also work closely with the Water Institute, so presenting some findings from Ecuador. And if you just came from the experiential session, this is going to sound familiar a little bit with some of the results. But to help bring everybody who may not be as familiar with the nutritional context, there's two really key indicators that we care a lot about during the first 1,000 days of life, during this really critical period of development. And one of them is exclusive breastfeeding for the first 6 months of life, and then providing infants with a diverse set of complementary foods so that they can grow and attain all the potential out of life. And so meeting these goals is associated with lower risk of GI distress and more likely to take up the nutrients in the diet, lower risk of malnutrition and stunting, and also implicated in potentially lower risk of future overweight and obesity. So thinking about the dual burden of disease. And water security is likely, as a lot of folks know here, and we just had a different presentation, WaSH context matters a lot for child well-being. A lot of literature to date has been looking at the infectious disease aspect of it. There was a great review that came out from some colleagues recently that was talking about how a lot of water security research is traditionally focused on diarrheal disease among this age group. There's many other pathways by which water issues may impact health and well-being. One of those being exclusive breastfeeding and dietary diversity. And we have some qualitative evidence suggesting that caregivers talking about shifting feeding practices and when they're experiencing water challenges, so maybe reducing how long they're breastfeeding because they're queuing for water, they don't feel like they have as many feeding opportunities, or also some quantitative data showing that piped water networks and other things are associated with better dietary practices. I'll throw in that one of the pathways through which this may operate is food insecurity. So water issues can cause limit what people can prepare and purchase, and then that can also go on to impact dietary health and well-being. And so the reason I'm bringing this up is because food and water issues often co-occur. This was from again, not my own paper, but a colleague's looking at the co-occurrence of food and water insecurity, and it's at really high rates, so it makes sense to look at these things together. So, as I noted, there's some limited evidence putting all of these factors together, so that is what I'm trying to do with these nationally representative data from Ecuador. And why Ecuador? I think this is a really great place to be working and focusing on this. Throughout the region of Latin America, exclusive breastfeeding duration is, well, it's all relative, but lower than we would like it to be at maybe around 100%, depending on needs and capacities, and only about half of infants are getting a diverse set of complementary foods. And in the region, stunting is really high, so as we just heard about, low height for age, it's a sign of chronic undernutrition. And at the same time, the prevalence of overweight and obesity among children under 5 is also increasing. So it's, I think the latest estimate is around 13% of children under 5 are experiencing that. So 2 main aims. I wanted to try to describe the burden of water issues in this throughout Ecuador, and then also examine their associations with exclusive breastfeeding duration, commercial milk formula use, and dietary diversity. These data are not my own. They are really great publicly available data that everybody can have access to. They've done 2 rounds of data collection through the National Institute of Statistics with great input from the Joint Monitoring Program, WHO, UNICEF, other groups to design the surveys. And the design occurred in 2022 to 2023, where they got a nationally representative set of households with children under 5. I won't go too much into the details, but you can think of it as there's, within each province, they're looking at urban and rural areas, they're picking select urban and rural areas to compare to, and then doing random sampling within those households. I subsetted the data to just the ones with children under 2, because that's the really critical window I care about with this analysis, but of course they have data for 20,000 households for children with under 5. So main exposure for water is water use and the water quality. I found these to be really great data because it is nationally representative data on E. coli in the water. So they collected water both at the source and the point of use, so what people are actually drinking and consuming. So sample those, plate those, incubate those, and then they classify risk on 4 different levels. So low risk being essentially no countable colonies, very high risk, which is what I mostly focus on in this analysis, is 100+ colonies. WHO classification, very bad water, you do not want to be drinking this. Food insecurity using a validated tool for the area, exclusive breastfeeding based on self-report, and then these other diet outcomes based on maternal recall of how infants were fed. Okay, that's a lot of the background, how this was all collected, very rigorous, good stuff. Let's get to the findings. I'll just say quickly, Ecuador has 3 main regions, so I divide up the results from the more coastal region, Sierra, and then Amazon, where there's a lot more indigenous people living, and it tends to have lower water access. I'll skip ahead. So that's kind of reflected in these findings. So in the coastal regions, almost universal access to basic drinking water services, a little bit lower in the Amazon. What's maybe the most shocking is the high contamination with E. coli. So in the Amazon, about 26% of households are using water that's contaminated with E. coli at the point of the source, much higher at drinking water. So about 1/3 of households are using water that is highly contaminated. Varies, of course, by the water source that people are using. So unprotected wells are the most likely to have contaminated water. And when we look at it, the JMP indicator is doing exactly what it is intending to doing, of capturing probable exposure to unsafe water. So the less than basic service level, about half of people had E. coli in that water source. who were the people most likely to be impacted? So having a piped water source, lower risk of having very contaminated water, makes sense. Lower wealth, being of indigenous background, higher risk. Lower maternal education associated with greater maternal education, lower risk of poor water quality, nothing with marriage observed. Very, very, very strong urban-rural component. Rural households much more likely to have contaminated water, and of course the regional differences. And these are all in one model put together, so these are all mutually adjusting for each other. So it seems like, if you're thinking from a programmatic standpoint of where to target, it seems like maybe indigenous households in rural settings in these two regions. So these are the findings of looking at the probability of exclusively breastfeeding to 6 months. So I did this just among the people who are 6 to 23 months old. This is self-report recall data. And you see two varying levels. So the high water, lower likelihood, very high contaminated water, higher likelihood of completing breastfeeding duration. In contrast, looking at commercial formula use, higher contaminated water, less likely to use. That makes sense given that a lot of the time these preparations are using water to do that, so you don't want to be using contaminated water to prepare your formula. That's seen at both folks under 6 months, 6 to 11 months, and no association at 12 to 23 months, probably given that it's also just less common to keep feeding your child commercial milk at that time. I want to address this kind of like seemingly contradictory relationship where one way at high contamination it's lower, at the other way it's higher risk. And I think there's maybe this threshold effect. At some point the coping strategies that you have to deal with it is you can no longer use commercial milk or other means, so then you have no other foods left, so you are just left to exclusively breastfeeding for longer. And that matches some qualitative data we've had in the past where people have said, I don't have good water, therefore I'm going to breastfeed for longer because I don't feel like I can prepare other foods safely. No findings with dietary diversity. Food insecurity, really strong associations with lower dietary diversity, but nothing seen for children 6 to 11 months or 12 to 23 months. I'll get to the last key messages of what I want to emphasize here is I was not capturing experiential data. I don't know the caregivers' perceptions of feeding. We were measuring E. coli in the environment. But there's a lot of evidence to suggest that people have a good sense of their water quality just intuitively based on taste, smell, the look of it, and it doesn't always perfectly align with water risk, but it seems like these data are suggesting that caregivers have some sense of the water risks and are adapting and changing their feeding behaviors for their infants to minimize that risk by doing things like exclusively breastfeeding for longer and not using commercial milk that could expose them to these pathogens that are really deleterious. Thanks for letting me ramble. Happy to take any questions. That was a whirlwind, but yeah, thank you.
Thank you, Josh. Any questions for Josh? Okay. Yeah.
Yeah, fantastic analysis. Were all of those very high risk contamination?
Yes, so what I reported was for like the early analysis was everything was in reference to very high risk versus low risk. In the full paper under review, you can see the different levels, and there is definitely a like monotonic stepwise progression for the risk factors that we were showing. So you do see some gradations for some of the looking at who's most likely to be impacted. It's increasing severity of rurality for the very high or not. So, yeah.
And you did analyse by water source type, which I saw.
Yes.
Did you also analyse by sanitation?
No, that would be maybe a next additional step to look at the sanitation types, and maybe that, are you thinking like cross-contamination of, yeah, that would be great. I also think that a component to look at would be storage water and seeing how people are storing their sources.
Thank you, that was really interesting. You talked about diverse foods from 6 months. Could you just say a little bit more about what you mean by that?
Yeah, again, way too much information on slides. It's easy to do this when you're at home. Dietary diversity, typically this is an indicator that is supposed to measure a child's risk of not getting enough nutrients, so it's not looking at the overnutrition component, but it is these sets of food groups have consistently been shown if you consume 5 or more, you are more likely to have what we are calling a diverse diet, and you are at lower risk of undernutrition, so less likely to be wasted, less likely to be stunted. So we use this as a global benchmark. ND, this is the survey I was thinking for a second. This is about the granularity of the diet data. They have a little bit more, so not the most rich diet data of like actual quantity, but they do have quite a bit of infant nutrition, so if anybody else wants to do other analyses, again, this is really a rich data set.
Thank you.
Yeah.
Right. Any more questions for Josh? No? All right, thank you.
Thanks, y'all.
All right, our next presenter is Christine.
So good afternoon, everyone. I'm Christine Marie George, and I'm a professor at Johns Hopkins. And it's my pleasure today to present on our randomized control trial of the Preventative Intervention for Cholera for 7 Days, or PICHA-7 WaSH program, which was conducted in the Democratic Republic of the Congo. And this work is a collaboration between my research group at Johns Hopkins, Catholic University of Bukavu, and the DRC Ministry of Health. And the rationale behind our work is that when a diarrhea patient is presenting at a health facility, their household members are at a very high risk of subsequent diarrheal diseases during the 7-day period after the patient is admitted to the health facility. And for example, for cholera, the risk is 100 times higher. And this is thought to be because they're sharing the same contaminated environmental sources, such as drinking water, and through person-to-person transmission through, for example, a lack of hand washing with soap in the household. And despite this high risk, there's very limited interventions for this population, with the standard of care focusing solely on the treatment of the diarrhea patient and not trying to reduce subsequent diarrheal diseases among the household members. And so this led us to our work, which started in Bangladesh, with the Cholera Hospital-Based Intervention for 7 Days, or CHOBI-7 WaSH program. And our approach to delivering our targeted WaSH program is that it's health facility initiated. We have a health promoter go bedside to diarrhea patients and their accompanying household members and deliver a pictorial WaSH module on hand washing with soap, water treatment, and safe water storage. And then these behavioral recommendations are accompanied with a hygiene kit, which is shown here, with a hand washing station and a water vessel with lid and tap and chlorine tablets. And then the behavioral recommendations from the health facility in our initial version of the intervention were reinforced through home visits during the 7-day high-risk period. And so we conducted an initial randomized control trial of this approach in urban Dhaka, Bangladesh, among cholera patients, and found that delivery of the CHOBI-7 program resulted in a significant reduction in culture-confirmed cholera among the household members of cholera patients, as well as sustained WaSH behaviors out to 12 months. And so we partnered with the Bangladesh Ministry of Health and Family Welfare to look at approaches to scale this program. And so they asked us to broaden the scope of the programs to include diarrhea patients of all etiologies, so the program could benefit millions more beneficiaries, as well as develop a scalable approach for program delivery that did not involve home visits, because in an urban context in Dhaka, Bangladesh, it would not have been realistic for promoters to go out to the homes of all these patients. And so this led to our later work where we added a mobile health component. And so we developed through community-centered formative research the CHOBI-7 mHealth program. And so here a physician from a local diarrhea treatment center calls and texts patients, and these are automated, to remind them to wash their hands with soap, treat their water, and also to safely store their water, not only during the 7-day high-risk period, but weekly calls during a 12-month period after the patient is discharged from the health facility. And so we conducted a later randomized control trial of this program in Bangladesh among 2,600 participants and found that this program significantly reduced diarrhea, not only during the 7-day high-risk period, but sustained out to 12 months, and also reduced stunting among children under 2 years of age. And we published this work in Clinical and Infectious Diseases. And so we were really interested to see if this same type of targeted intervention approach could work in a sub-Saharan African context, which is very different in terms of much higher water scarcity, higher household sizes, and much higher food insecurity. And so this led to the development of the Preventative Intervention for Cholera for 7 Days, or PICHA-7 WaSH program. And our research site is in Eastern Democratic Republic of the Congo. We work in both North and South Kivu. And this work that I'll present today is funded by Wellcome. And so the Preventative Intervention for Cholera for 7 Days, or PICHA-7, and PICHA means picture in Swahili for the Pictorial WaSH module that's delivered as part of this program. And again, 7 is for the 7-day high-risk period for subsequent diarrheal diseases for the household members of diarrhea patients. And so similar to our CHOBI-7 program in Bangladesh, this program is health facility initiated, where a promoter is delivering a pictorial WaSH module in the health facility to diarrhea patients and their accompanying family members. We provide the same type of hygiene kit. And in our urban setting in Eastern DRC, there's a community health worker infrastructure. And so we were asked by the ministry to also have quarterly home visits, which would be integrated if it was taken into scale with the ongoing community health worker program. And then finally, we had our mobile health component, which again, similar to CHOBI-7, is sent by a physician at a local cholera treatment center that sends out automated weekly voice and text messages to diarrhea patients and their household members. And to give you a sense of the cost of the mobile health component, it costs around $2 US to send out weekly voice and text messages for 12 months to diarrhea patient households. So a very low cost approach to provide reminders on the key WaSH behaviors. And so we conducted a randomized control trial of the PICHA-7 program in urban Bukavu City, which is in South Kivu province of DRC. And this trial was among 2,334 participants, and they were randomized to be in one of 2 arms. The first arm received a standard message given in DRC by the government on the use of oral rehydration solution for dehydration, as well as a basic 5-minute WaSH message. And then our second arm received the same standard message plus the PICHA-7 program, which I described. To recruit diarrhea patients, we had ongoing health facility surveillance in a total of 115 healthcare facilities in South Kivu province of DRC. So diarrhea patients were recruited from these health facilities for our randomized control trial. We also have an enteric disease microbiology laboratory, which we established in 2017, where we analyze both water and stool samples for enteric microbes. And so the design for our trial is that we recruited diarrhea patients and their accompanying household members at baseline in the health facility. And we also made home visits to recruit the household members that were not present at the health facility. We followed diarrhea patient households longitudinally for 12 months. And this included monthly clinical surveillance visits to obtain information on diarrheal disease, in particular diarrhea, or 3 or more loose stools in the past 24 hours in the past 2 weeks. We also measured the height and weight of children at baseline and a 12-month follow-up. And for our intervention fidelity indicators, we conducted 5-hour structured observation of hand washing with soap practices and conducted unannounced spot checks to assess stored drinking water quality relative to E. coli, and we also measured free chlorine concentrations. Now I'll go into our WaSH findings. So we found that delivery of the PICHA-7 program resulted in significantly higher hand washing with soap, not only during the 7-day high-risk period, but sustained behavior out to the 12-month follow-up, in comparison to much lower hand washing with soap in the standard arm. Next, we observed significantly higher free chlorine levels, and our cutoff we used was we were looking for levels that were greater than 0.2 milligrams per liter in stored drinking water. And this was significantly higher, again, not only during the 7-day high-risk period, but sustained out to 12 months in the Pitcher 7 arm compared to the standard arm. Next, we looked at stored drinking water quality relative to E. coli and found that in the Pitcher 7 arm, a significantly higher proportion of households had less than 1 colony forming unit per 100 ml of E. coli in their stored drinking water. And so these WaSH findings overall showed that the Pitcher 7 program was effective in increasing WaSH behaviors, not only during the 7-day high-risk period, but sustained out to 12 months. And so now I'll go into our health outcomes. We found that delivery of the Pitcher 7 program significantly reduced diarrhea prevalence over the 12-month program period, and this was part of our monthly clinical surveillance. And so we were collecting information on reported diarrhea monthly over a 12-month period. And one of the interesting findings was that this reduction in diarrhea prevalence was not only for children under 5 years of age, but for all age groups. Next, we were interested in looking at severe forms of diarrhea, and in particular cholera. And so we measured diarrhea with rice water stool, which is a hallmark sign of cholera, and we actually have an ongoing serological analysis where we're looking at serological markers for cholera. But for this self-reported outcome, we found a significant reduction, and it was actually a more than 50% reduction in reported diarrhea with rice water stool among participants in the Pitcher 7 arm compared to the standard message arm. We also looked at health facility visits for diarrhea, and this was also significantly lower in the Pitcher 7 arm compared to the standard arm, and again, more than a 50% reduction. And so this showed that this intervention was highly effective in not only reducing diarrhea, but also severe forms of diarrhea. For our final outcome, we looked at stunting for children that were under 5 years of age. And as you can see, we measured this at baseline in our 12-month follow-up. We found that at baseline, stunting was high in both arms, with more than 50% of children being stunted and the stunting rates being similar between the arms. And then at our 12-month follow-up, we observed significantly lower stunting among participants in the Pitcher 7 arm compared to the standard message arm. And this was a 19% reduction in stunting that we observed. So in summary, we found that delivery of the Pitcher 7 program significantly reduced diarrhea prevalence over a 12-month period. It also reduced severe forms of diarrhea, including health facility visits for diarrhea, as well as diarrhea with rice water stool. We observed a significant reduction in stunting for children under 5 years of age, which was consistent with our finding in Bangladesh in the earlier study that I reported. And we also saw significant improvements in WaSH behaviors, including increased hand washing with soap, water treatment, and stored drinking water quality. And so in conclusion, we found that delivery of the Pitcher 7 program presented a promising approach to increase WaSH behaviors and reduce diarrhea, as well as reduce stunting. And the really innovative part is that we integrated in-person visits with mobile health messaging. And so we would like to encourage people to consider integrating this type of approach into their existing WaSH activities. And so this leads to my final slide on transformative WaSH. And so we're always having discussions around transformative WaSH, and we observed that delivery of this targeted intervention approach that had in-person visits and mobile health messages resulted in a significant reduction in diarrhea and stunting in both Bangladesh and in the Democratic Republic of the Congo, two very distinct contexts. And so these findings suggest that this is a very promising approach. And as I mentioned, that public health practitioners and WaSH practitioners should consider including this as part of their WaSH programming. And so with that, I end my presentation, and I would like to acknowledge all of our study collaborators, including my colleagues at Catholic University Bukavu, my colleagues at the DRC Ministry of Health, and those at Johns Hopkins, including Kelly Andreas, who's here today, and will be presenting on Wednesday on some of our other WaSH-related work on cholera, as well as Elizabeth Thomas, who's also here. Thank you.
Thank you, Christine. Any question for Christine? 1, 2. I'm just checking the room. Any more questions? All right.
And my email address is here if you want to ask me any other questions.
Go ahead. Yeah.
Thank you, that was so interesting. I'm looking forward to reading that paper. From what you've said, I've understood that there's kind of almost like 3 mechanisms happening within what you're doing. That it's like you're catching people at a really teachable moment where they were maybe quite scared and worried for their family member. You're giving them some hand washing stations, so it's like an infrastructure kind of thing, and then you're also kind of making them quite accountable by talking to them regularly about this. And I was wondering which of those 3 you think is like the key thing that makes this more successful than other similar like hand washing interventions.
So that's always the tricky part, and you had it right on in terms of the very, yep. So that was an excellent question, and it's always a tricky part to untangle which part is really contributing to the health impacts and the increases in WaSH behaviors. And so we know that we targeted a very high-risk population. When we looked at stunting, it was over 50%, diarrhea rates were over 30% for children under 5 years of age. And so we don't really know which component contributed the most. We know that from our qualitative work that people really liked the mobile health messages. They said that the physician, Dr. Pitcha, who was calling them, really cared about them, and they appreciated the follow-up after they left the health facility. We know from previous studies that enabling technology is a really important component to facilitate WaSH behaviors. And so the answer is that we don't know. But it would be interesting in future studies to kind of untease that by having different arms that have different components of the intervention.
Thank you.
Thank you, Josh.
Just those are really impressive findings, and I was curious, it sounds like there was a lot of really great partnerships and government collaborations, and I'm wondering how the response has been to the findings and the dissemination of these like huge impacts.
Yeah, so there was a lot of interest in the results from our study. And along with that, the interest around the effectiveness of the current WaSH interventions that are delivered for high-risk populations. And so we had another paper that came out that was led by Kelly Andreas, that's here, that showed that case area targeted interventions for cholera in this context really weren't working. And so we're hoping that the ministry will be interested in including mobile health as part of their other WaSH programming in the area. And also evaluating this approach in different contexts. And so we currently have funding to look to see if this approach would work in internally displaced persons camps and IDP camps. So seeing if this will work in a humanitarian context is the next step that we're taking with this. Thank you.
Hi Christine, thanks very much for the presentation. I think for the results on stunting, it's quite interesting, especially as the WaSH sector, to see some positive results on stunting. I wonder, like, in your adjustment in the analysis, did you adjust for different levels of service coverage of WaSH, like of water, of sanitation, and is there any kind of stratification that we can see that there's greater effects with certain service levels or otherwise?
So that would be something interesting to look at. Our study was randomized, and so WaSH infrastructure was similar in terms of like the type of sanitation infrastructure, the type of water infrastructure was similar across both arms. There wasn't any significant difference at baseline. But it would be interesting to look at that to see if there were certain groups that the intervention benefited more than others. So that's definitely something that we can look at. And I think that's something that really differs between our study and other studies is that most other studies were community-based WaSH, and so they were including very large populations of people who were not sick, didn't have any recent experience of illness, and also didn't have diarrheal disease or stunting rates as high as ours. So we think that our finding was successful because we were targeting a very high-risk population when WaSH messaging, they were most resonated with them.
Was there at a point where the participants could contact the health workers in case there was any challenge?
Yeah, so they had the numbers of the health promoters, they could call them. We didn't go into a lot of detail because we have a side session that's actually on Thursday that I should have mentioned earlier on transformative WaSH. And so we have a session on Thursday in Mount Laurel at 1:30 on how you can leverage mobile health for transformative WaSH. And so we'll talk about the process evaluation for the mobile health component, but it includes interactive voice response. So participants are asked questions about their WaSH practices, how long should they boil their water for, how long should they put the chlorine tablets in, and then they respond by pressing 1 or 2, and then they get a response back from the doctor. And so that was kind of the interactive component. And in our qualitative work, people found that they really liked that component. And again, Dr. Pitcha cared about them.
Amazing. Thank you so much, Christine.
Thank you.
So our last presenter for the session, Alison Parker.
Hi everyone, so something slightly different to finish the day off, although it's been a really kind of quite broad mix of presentations in this session. So I'm going to talk about legibility in sanitation and water in informal urban settlements, lessons from a multi-country longitudinal study. I have a lot of co-authors, some of whom are in the room. So Alicia, who's our chair, which is a bit of a coincidence, but she's been one of the collaborators. I can see Corey at the back. Danny said she was going to be here, but maybe she hasn't made it, but Danny's here in the conference as well, and a few others. So yeah, to put faces to those names, and I really want to acknowledge those people. You know, I'm standing here on a podium today, but there's been a lot of work by those people and people who aren't in those pictures and those organisations to bring this together. So I really want to acknowledge that contribution from those guys. So we know that people who live in informal settlements have different options for water and sanitation that constantly change depending on how functional facilities are and their maintenance, depending on personal perceptions of safety, depending on what people can afford that day, and a whole tapestry of changing access rights for communal systems. And making society legible often leads to misrepresentation and oversimplification. And this is what Scott said in 1998. And he's got like quite a long book that talks about this, but I'm kind of trying to draw out some of the sort of simple version of what he was saying today. So yeah, complex environments like informal urban settlements. And government policies seek to govern the health and well-being of these populations, but don't account for the complex localized realities on the ground. So legibility carries with it a responsibility to act. Once you've actually sort of defined the system, then you have a responsibility to act to make it better. And the very process of making something legible brings in this duty to act. So this led us to these research questions. So how do people cope with inadequate services in informal urban environments? What are the implications for these coping mechanisms for the design and management of service delivery systems? And what are the implications for how we monitor such contexts? So we had a method, we're coming back to mobile phones again, which seems to be another theme for this session, but we had the opportunity to do a longitudinal survey using smartphones. So we had 300 people in 3 different informal settlements who completed a smartphone survey basically every day. And every day they did a survey and they got paid like a small amount of money for every survey over the course of a year. So this gives us a fantastic longitudinal data set, which is about a whole bunch of topics. So just to give you a kind of picture of how our survey is divided up. So we had 3 countries, 100 respondents in each country. We had a focus, I'm not going to talk about container-based sanitation today, but the overall project had a focus on container-based sanitation. So we had 50 CBS users and 50 CBS non-users in each country, and we were aiming for an equal mix of male and female, but we did actually end up female-dominated because of the way the recruitment kind of panned out. And then they had a whole bunch of surveys on all sorts of topics on water, sanitation, things related to elections, shocks, things related to electricity, social network analysis, and those were repeated either weekly or quarterly. So we have this fantastic rich data set of what sanitation people are using, what they think about it. So it's a really huge data set, which I'm going to pull out a few little bits of today. So these are our 3 study sites. They were deliberately picked with CBS in mind. So we have Peru, Lima and Sanima as an NGO we were working with there. We had the city of Cape Town in South Africa, and they're a municipality delivering CBS. And we had Sanaji in Nairobi in Kenya, and they're a social enterprise delivering CBS. So those are the 3 study sites that we used. And these are some examples of the survey questions. There are like several hundred questions, so I haven't given you all of them, but this just gives you a kind of idea of the types of questions that we were asking people in the survey. So I'm going to give you a few graphs of the results from the survey. So one of the questions we asked was what people's primary toilet was. So what was the primary toilet they were using that week? So what you'd expect is that people would always be using the same primary toilet. So we'd expect the majority of the responses to be sitting on the left-hand side of this graph under 1. But as you can see, Peru had the most at 38%, but quite a lot of people are using a number of different primary toilets across the year of our survey. And that tail is quite long. We're getting up to people using 7 different primary toilets across the length of our survey. So the idea of like people using the same toilet every week is just not true according to our data. And this is like dividing up the data a slightly different way. What is the mean number of toilets people in each household used each week? So again, you'd expect it to be 1, or well, would you? But 1 is like one idea. But you can see there's a really long tail of the number of households, number of toilets people in a household are using each week. And actually, that does make sense when you think about it. Like, because people, like, we don't use 1 toilet all week unless you have a really kind of dull week where you stay at home. You're going out to work, you're going to church or to another place of worship, you're going to the market. So there's lots of different toilets that you use every week. But obviously, lots of recording mechanisms and metrics talk about the 1 toilet that you use. But actually, most people are using multiple toilets. Looking to water. This was a really hard one to try and like work out what sensible way to present this data was. So what we did was we looked at the water source that people were using every week, and then we looked at did it change to the next week, and did it change to the next week. So on this graph, if there's the households that got 60% change, that means 60% of the weeks they were using a different water source than they were using the week before. So they're really regularly changing. And of course, there are some countries, so in Peru, 62% of people never change their water source over the whole year of the survey. But in Kenya and South Africa, people are changing water source. Most people change the water source at least once over our year-long survey. And again, splitting the data down per week, this is the mean number of drinking water sources people use in each household every week. So here we are kind of going to what we expect. Most people are only using 1 water source per week, but there is still that long tail up to some households using more than 1, or using quite a lot of sources per week, but most people are only just using 1. So this kind of complexity is mostly illegible within the formal monitoring systems like the WHO and the JMP, which categorise households based on their primary system without accounting for this wider service infrastructure. So citywide inclusive sanitation and other area-wide approaches are starting to get onto this and thinking about that wider range of sanitation and water options that people are using in a week. But because of the failures of services, so things falling into disrepair, mean that people are switching services quite often. So really we need to think more about a service ecosystem. So rather than people using 1 service, we're thinking about a service ecosystem of people using an interconnected network of diverse services, systems and actors that collectively meet the needs of individuals or communities, particularly in urban informal settlements where formal centralised infrastructure is absent or unreliable. And the knowledge could lead to the knowledge and the granular knowledge that some of the metrics imply doesn't address the deeper structural issues that underpin service provision, like land tenure insecurity, political exclusion, financial unavailability of finances. So I wanted to finish off. I hope I've kind of piqued your interest in how people, how these traditional metrics for measuring water maybe could be improved a little bit or a lot. And I want to point out we have all our data online. So if this kind of data interests you, and this is just a tiny snapshot, we have a huge data set online. Our project is now finished. We've kind of run out of resource to analyse this. So please get online. We're required by our funder to put our data online, so it's there on the reshare website. So there's a whole load of data about all sorts of stuff, and we'd really love anyone else to go and download it and do some kind of analysis on it. So because there's loads more this high frequency longitudinal data set. And I also wanted to plug my colleague Danny, who I can now see at the back. She's got another presentation focusing more on the container-based sanitation aspects, and that's on Wednesday at 3:15, and focusing particularly on intersectional vulnerabilities, because that's another really important aspect of water and sanitation services.
Any question for? Okay, I'll start with Christine and then,
So my question was an excellent presentation, and as you know, I'm very excited when I see that people are using mobile health as their platform. And so I'm curious whether you customize your own platform or whether you use the existing platform that you recommend that WaSH practitioners use.
So we use the Open Data Kit platform. So that was definitely not me. That was our colleagues at Bangor University who really did all the technical back end of that. I'd say it was really, it gave us some really good data. It wasn't like as easy as it was in my mind at the start of the project. Like rolling it out in context where you either have to give everyone a smartphone, which has its own challenges, going around slums giving out smartphones, or you have to rely on people's own smartphones, which some of them were quite, a really low-end smartphone is going to really struggle with ODK. We've got a whole paper coming out called Lessons in Smartphone Surveys. I say it's coming out, it keeps getting desk rejected from journals, but I think it's now under review. So there's a whole paper coming out, and I could send you a draft of it. We had some interesting experiences. It wasn't easy, but I think like enumerator-led surveying isn't easy either. And to give us the richness of that data set over the year, I think it was worthwhile, but it wasn't plain sailing.
So all the participants that you targeted had their own smartphones then?
It was a bit of a mix. So in Kenya we had a really good scheme where there was someone who was already renting out smartphones, so we just gave them the money to rent the smartphone, and that took out that problem. In South Africa, they thought everyone had smartphones, and then they realized that some people didn't, and we wanted to make sure we were targeting vulnerable groups. So, female-led households and that type of thing where they might not have had a smartphone. So then they started giving out smartphones, and then it got out that people were being given smartphones, and they ended up giving out a lot more than they expected. But
that's interesting. In our context, both in DRC and in Bangladesh, less than 50% of people have smartphones. Most people have feature phones, and so we send our messages out using
these are urban contexts. So the penetration of smartphones is quite high. But like I said, it was something we were really having to debate at the start of the project, is did we give out phones or did we expect people to have their own phones? And there was a different kind of, if you had your own phone, you got paid more than if you were being given a smartphone, because they got to keep the smartphones at the end of the survey. So there was quite a complicated reward system.
Yeah, thank you for your presentation. I think you mentioned a social network analysis.
Yeah.
I missed if you said that you had conducted that already or planning to.
Yeah, so that was in one of the modules in the smartphone survey, was on social network analysis. So we were asking people questions like, how did you hear about, particularly on the CBS side, how did you hear about CBS? Would you recommend CBS? What do your neighbours think about it? So there's a whole, I can't remember all the questions off the top of my head, but there's a whole module in that. So if you go on the Reshare site, you can look at that and find all of those questions. So, yeah.
And then, quick follow-up. How did you land on social network analysis instead of another kinds of systems thinking tool? Because you mentioned how complex informal settlements are.
I think to be honest, we just had a massive brainstorm at the start of the project of what are all the questions, with all our 10 different university stakeholders, what are all the questions that people wanted to put in, and there were people that are interested in social network analysis, so they put a load of those questions in the survey. But yeah, it was more of a kind of democratic process across all the partners. We've done a lot of analysis on, so we did a lot of political economy analysis as well, and we've used photo voice, which is what Danny's going to be talking about on Wednesday. So there's quite a lot of different types of methods as well as the smartphone surveys, so we've been able to triangulate across all of them.
Gemma had a question? Oh, sorry, Claire.
Oh, sorry, was it me? I I was just wondering about the making urban spaces more legible. Like, are you planning to do more analysis about that? You know, like who is using more toilets, or kind of breaking it down a bit further?
Like I said, we've kind of run out of resource on this project to do any more analysis. So we're kind of hoping that some like other people are going to come along and take it on for us. So yeah, there's a few bits and pieces coming out on. So there's we had a master student this summer do a really cool project on families, like people with children and how their use differ to people without children. What else can you think of on that, Alicia? Yeah. So yeah, there is more stuff to come, but like there's more. Yeah, we kind of in that process of let's ask a bunch of questions. We kind of got carried away, and we now have a lot of data, and it takes so it's something like 30,000 data points. So yeah.
Yeah, just we have more time. Any question for any of our presenters, in case you missed anything and you would like to ask a question? None? Okay. Thank you all for being such a great audience. We have 30 minutes left. And you can head over to the atrium for networking, for snacks. But thank you all very much and hope to see you all soon.
I would like to ask a question. I was supposed to attend the session when I
It's been quite like a new thing, like totally even quite fascinated by like the basic use this the Mango guys wanted they're like ecosystem services guys, so I was like they usually more actually so it's definitely that's it. These are
not had to find the fourth time. Okay. So my flow has been this paper.
Yeah.
So 10 minutes.
Yes. Yeah. So they should be there. And the information session. They regularly are on time. All they have to do is to let them know if they're getting close to the time.
I mean, if you get too deep, you're going to go to our
Is it a verbal presentation? Or is it you know the guy we have a video of our presentation. You'll be the best person to do that. Yes. So how are we?
I have, yeah.
Do you know the
area?
So if you have that book, do you have the book?
That was just for vacation.
Yeah, so if you have the book,
but I know you have jump all over there as well.
So did you say tomorrow? What time?
No, we could definitely find another time to talk. Sounds great. Nice meeting
I'll just go and show you. Yeah, so I'm just
I got it right. Like, if it's a 5 minute room, they will be managing. I need to
Yeah,
do it.
just tell them if it's like being very empty, let's say level 55, and it's like level 15, just like tell them what 5 minutes is. Because they like to manage their own thing, but if it's like this verbal presentation thing, it needs to be. They're not taking it, they actually forgot about it. So remember like during the training, and then what happened in training, they're like, list of our priorities.
Probably they're just keeping it as a backup option in case something goes wrong, something will be there.
Something will be there, and it's not, I don't think it's that much of a
So, I'm coming from the like experiential water side, so these data were available and I was like, again, the reports of like qualitative reports of that hand and I was like, well, it's water quality of media, but like actually that's more predominant than sometimes people talk about scarcity of use, so perceptions of water quality.
Connection, people
I just had to
from everywhere.
how
This is the water to be in Somalia.
and that's what kind of led to it. And then imagining that so I wish we had the data to compare seriously if there how people have actually suffered about it. And then I think that draws the connection a little bit better with the behavior changes. Yes, because yeah, I was going to ask you about, so,
what language?
innovation that was going to acute malnutrition versus severe acute malnutrition is
That's correct. So then it doesn't, the presentation on Cathy,
okay,
that's not working.
as opposed to less than 2. I was curious.
I'm not, but I'm discovering some. I've just come back to try ACF and I discovered that now.
Good.
And I know that right now in Colombia, GHF on Somalia as well. Definitely something that
I also saw colleagues did a review that was looking at previous studies looking at WaSH in relation to okay. Okay, well then I don't have to apologize to you because I was a reviewer for that paper and I was like, I hope I didn't yeah, and I was like, hey, this isn't otherwise, yeah, I want to be self-inspired.
there's a lot to do, but we're being